So I hope you'll have a great day. And I'm looking forward to this lecture. And we are used to talk now in Zoom, and I don't have any connection with you, but if you have questions, please send them over and I'll answer later on. I'm Deborah Schwartz-Arad from Israel, from Tel Aviv. I'm an oral maxillofacial surgeon, and I also have a PhD in cancer research. And if you look at my CV and papers, I do a lot of augmentation procedure, orthosurgery, and implantation. I do a lot of research on those subjects. I wrote about 100 papers on this, but let's go over to the lecture. And before, I just want to show you the area where my surgical center is located in Tel Aviv. This is a very nice part of Tel Aviv, in north of Tel Aviv. And you can see here in this picture on the right, the entrance to the surgical center. Actually, in the surgical center, we have two areas. One is the dental clinic with all the doctors are specialists. And on the other hand, we have two operating theaters for both oral maxillofacial surgery and plastic surgery. We have also ENT specialists, so we do everything there. Actually, our motto is facing forward, both for using the best materials and digitization and all new, and being at the cutting edge of the modern technologies. And on the other hand, to see the face as the holistic and give the solution for aesthetics and function as well. So my topic is a concept of treatment in patient with atrophic maxilla. And actually, I called also this part of several lectures that I give from oral to facial. משהו התקלקל להם. So if you look at these 4 patients that approach my clinic in the last few years, you can see several things. First, you can see the problem that they miss teeth, sometimes both arches and sometimes only in one arch. But if you look at them, this is not the first thing that jump out of this picture. The problem is aesthetics. The problem is less of support to the facial tissues, to the upper lip, to the tip of the nose, to the lower lip, to the cheeks. So today, I would like to present 2 of these women and to talk with you about my concept, how to treat these patients. First, let's go over the facial aesthetics. We do it very fast because you deal with it almost every day and you learned in school, but just to remind you that we have to look both vertical and transverse proportion. If you look at the profile view, the nasolabial angle and the lips fullness and position are highly influenced by the position of the upper jaw, the maxilla, and the location of the upper teeth. The labiomental angle is influenced more in the by the position of the mandible and the lower teeth. Today, we are going to talk only about the maxilla. If we look at the transverse and vertical proportion, we all know the 3/3, both on the vertical and the horizontal. We have this 3/3. More lines that are important to remember is 1/3 and 2/3 of the lower facial proportion. We can also have 2 halves if we move from the nose, the base of the nose to the chin, and we cut it in the lower part of the lower lip, then we get 2 halves. As I said, today we will deal with this part, with this 1/3. So the topic of my lecture today is maxillary atrophy acquired class 3. Treatment concept will be divided into phase A and phase B. If we look at phase A in these treatment modalities, I'm talking about vertical augmentation. The easiest part for vertical augmentation in the dentulous maxilla, atrophied maxilla, is via sinus augmentation in the posterior part and subnasal elevation procedure in the anterior and middle parts of the dentulous maxilla. The horizontal augmentation I do via intraoral autologous bone block graft. And usually I do simultaneous implant placement. So these 3 operations or modalities I do as a phase A procedure. So let's see the first patient. So this patient is about 54 years old. She was referred to me like 6 or 7 years ago, and you can immediately see the problem. She missed teeth for quite a long time in the upper jaw, and she has a maxillary atrophy and acquired class 3 malocclusion. And it, without the teeth and even with the teeth, it highly influence the upper lip, also the cheeks, and you will see later on also the nasolabial area. If we look closer with her teeth, the way she came to me with the denture, of course you see the negligence and also the position of the upper jaw with this denture. If we look at the maxilla on the panoramic view from the CT scan, this is a panoramic view for the CT scan, we can clearly see the pneumatization of the sinuses, the maxillary sinuses on both sides, the right and left side, and the huge atrophy, severe atrophy of the maxilla. Nevertheless, if we look at the slices in the anterior maxilla, one can see here the nasopalatine duct, the floor of the nose, the nasal floor. This is here, if you see my pointer, this is the alveolar bone and the anterior nasal spine. If we look at the middle and posterior maxilla, one can see that the nasal floor is located way posteriorly till the area of the premolar and even the molar areas. So if we want to place implants at the posterior part, sinus elevation procedure will not be sufficient to get vertical augmentation there. That's why we need to place a bone like in the nasal floor. So subnasal elevation procedure will be performed as well. In era where easy treatment or small implants and all-on-4 is so popular, I would like to pay attention to this treatment who gives back not only the position of the teeth in the correct position, but also aesthetic, phonetic, and supporting the facial tissues. Here you can see the intraoral view and the panoramic view of the same patients. You can appreciate the amount of bone and tissues are missing due to the loss of teeth and the loss of alveolar bone. So she is a severe class 3. severe acquired class 3. She was not born as class 3, but she's acquired class 3. So the first operation would be vertical augmentation, sinus augmentation procedure with subnasal elevation procedure, horizontal augmentation via intraoral autologous only bone graft, and simultaneous implant placement. You will see in this video that we use template, that conventional template to place the implant. Today we do everything digitally, as we will see at the second patients. So here you can see the operation. A mid-crestal cut was performed without vertical incision in the aesthetic area. Subnasal elevation procedure and sinus elevation procedure via lateral window technique. And here you can see gentle separation of the Schneiderian membrane, and you can see the tear here, the perforation of the membrane, which will be corrected during the operation. The left window is done. And here you can see the conventional template. We planned implant only at the posterior part to prevent any interference with the prosthesis later on, since she is such a severe class 3. So I wanted to give freedom to the prosthodontist with the prosthesis at the anterior part. And here you can see the filling of the bone, the augmentation, with xenograft material saturated in bone marrow. It can be also saturated in PRP. And this is the block graft, the monocortical block graft, harvested from the ramus and fixed with 1.1 self-tap titanium screw to the basal bone. More bone was harvested from the symphysis, and a lot of xenograft material and also the window itself were used. And after releasing incision, placing the PPP, platelets pour plasma, bearing the implant, and this is a buccal fat pad. It's a pedicle graft who gives support and volume and also vascularity to the area of augmentation. I do it in each operation, whether if it's orthognathic surgery or augmentation. So if you look at the slides from the operation, one can see here the perforation of the Schneiderian membrane, the right and left sinus augmentation, and the subnasal just prior to the filling with the material. And here is the biomaterial, the xenograft, saturated in bone marrow this time. I use sometimes PRP, and the blocks that were harvested from the left ramus and from the symphysis for horizontal augmentation. Everything was covered with PPP and with the buccal fat pad pedicle graft. This is sometimes called the Bichat, and it lies between the buccinator muscle on the medial part and the masseter muscle on the lateral part. And to get there, actually I penetrate the buccinator muscle and pull some of it, just very small part of it, forward anteriorly without interfering the vascularity. It's a pedicle graft, this why it's vascularized. So it helps in volume and vascularity and protect the entire augmented area. Here you can see immediately after operation, the panoramic view, and one can see here the heels of augmentation in the subnasal area, in the sinuses, right and left. Also the screws that hold and fix the plates, the monocortical plates harvested from the ramus and symphysis. And we wait 9 months. 9 months later, and uncovering is planned. For this, we prepare the first transitional prosthesis, which will be screwed to the implants. Also, I would do at that time, I will do the connective tissue graft for further volume to the buccal area. So let's see the operation 9 months later. So I place the multi-unit abutment in 21 Newton per centimeter, and then I harvest connective tissue from the palate, from both sides, to the buccal side, to the facial side, and then we adjust the first transitional prosthesis, screw-type prosthesis. I took a sample from the area of augmentation. You can see here the holes of the screws that I took out and the nice incorporation of the blocks to the natural bone. So it's very interesting to see what's going on there. So look at this biopsy sample taken from this. So one can see this is in high magnification. This is the new bone, the pink with the osteocyte inside. It's a vital bone, and those are the particles left from the bone that I added from the xenograft material. So one can appreciate the amount of new bone formation here around the particle without, of course, any infection. If we look at the picture and of the lateral view, the profile of that lady prior to the surgery, and the cephalometric lateral view of the same lady prior to surgery, and then we compare it to the post-op profile and post-op cephalometric, one can appreciate the difference in the look and support of the tissues. Nevertheless, and here is 6 years later, and we can see that it is in a stable condition. If we look at the final work done by one of my colleagues, this is the final prosthesis that she has. Look here, this is how we started a severe maxillary atrophy, severe acquired class 3. And this is the final prosthesis. One can be very pleased with the result. Nevertheless, we have to be very criticized in our work and not to be so pleased, and always try to go forward and to make things better. If we look here, we see that in this area where she needs to clean, so we have to leave it in this way. It's not a removable prosthesis, it's a fixed prosthesis. So we have to leave a place for cleaning. This gives less support at a very important area, at the nasolabial area. Although she sent me this picture just a few weeks ago, and she's very happy with the results, and this is already, as I said, 6 years later, she really changed herself and she lives very good with herself. I'm not so pleased. And I would like to share with you why I'm not so pleased with the results. If we look when she talks, while she talks, you can see a very problematic area when she gives a big smile. This is the area under the nose, the flabby lip and horizontal upper lip wrinkle. This is due to the fact that there is not enough support because she was in such severe class 3. I couldn't recover the entire missing tissues only by the augmentation procedures that I've done horizontally. Even in the International Statistical Classification Diseases and Related Health Problem, the ICD, which is medical classification listed by the World Health Organization, They recognize today the acquired class 3 as class 3. So you don't have to be born as class 3 to be treated as one. I want you to pay attention now to what I'm going to say. And this is very important for me and for you as dentists who treat those patients and give them the different opportunities of treatments. You have to think of those patients as acquired class 3, like they were born like this. How would you treat a patient with a class 3 due to a retruded maxilla? The answer is advancement of the maxilla. Advancement of the maxilla is the right treatment for patients who has class 3 due to retruded maxilla. So Le Fort 1 advancement osteotomy would be the answer for those patients as well. And this is phase B. So the treatment philosophy is maxillary advancement by Le Fort 1 osteotomy. And this is a concept. I give lectures many years now, and I would like you to just break the wall and break the roof of glass and think differently and accept it as you would accept a patient, a young patient who needs this operation, because this would give the best aesthetic result. And if we look at this paper that was published in 2014 on the difference in three-dimensional soft tissue changes after orthodontic surgery in skeletal class 3 patients, we know today that in the nose, cheek, and upper lip areas, the greatest changes were seen in the Le Fort 1 group. So that's why I call this lecture From Oral to Facial Surgery. So the management of severely resorbed maxilla in class 3 relation by means of Le Fort 1 osteotomy would be first, phase 1, give the teeth first, and then do the Le Fort 1. So augmentation implantation would be the first phase, and the second phase, Le Fort 1 maxillary advancement. If you go to the literature, you would find that the small amount of papers that were written on Le Fort 1 for advancement of atrophic maxilla, they first do the Le Fort 1 and then they do the augmentation and implantation. And I think it's a mistake. The reason is that we have to treat this patient when we have the right location and a real clue for the class 1 as we have in patients with teeth. That's why I said do first the phase A and then the phase B. Let's look at that patient. She's 39 years old patient. When she entered to the clinics, she looks like a supermodel. And when you try to see the proportion in this patient, she looks quite proportional. She has a square facial face, but her middle third slightly decreased, but she looks quite good. If you look at the profile, now we see several problems. We see straight profile. We see acute nasolabial angle, droppy nasal tip, upper lip supported deficiency, but we have a normal gonial angle. The normal gonial angle leads us to the idea that the problems might be lying in the upper jaw, in the maxilla, the tip of the nose, the drop of the nasal tip, the upper lip support deficiency, the acute nasolabial angle. All of this reason gives us the reason to think there is wrong support coming from the upper jaw. If we look at her closely in the static analysis, she has thick lips, which are very, might compensate of maxillary deficiency. But when she smiles, smiling deformity we have, and nasal tip depression, immediately the lips drop up, and we have a high lip line that displayed 100% of the clinical crown length. Now you see the problem. This is the CT scan of this 39 years old lady. She has lots of previous treatments. She lost all her teeth. She's healthy. She's past smoker, but she's healthy. And she lost the teeth due to the fact that she was treated in a very poor country. I'm not giving all her history. And she arrived to Israel and she wanted different treatment. She had 2 operations here in Israel already a few years ago of a sinus elevation procedure and implants, and everything failed, almost everything. If we look here, we can see 2 implants on the right, one on the right and one on the left. They are not integrated anymore, that are disintegrated to the bone, and 1 implant is not loaded at all. The 3 implants on the left seem to be okay, and she has another broken tip implant on the right side where you see the arrow. We have to think, when we take such a patient, what was the reason of failure? Because you don't want to go in the same route and fail again. So you have to take care to understand what made the failure, and you have to do, and you have to think what differently. So if you look in the lateral view, in the cephalometric, and also in the CT lateral view, I want you to pay attention to the position of the anterior nasal spine compared to the position of the tip of the incisor tooth that she has. So I made these lines so you can see them better. So the huge distance between the tip of the incisal area and of the incisors and the location of the maxilla. The reason that you don't see so much that there is a little bit of support of the upper lip is due to the fact that the position of the upper incisor is quite in the right location, which it should be, but the distance is huge. This is her facial scanning. Today we do everything digitally, and we scan the face as well as a CT scan, as well as the intraoral scanning. So this was in the first appointment. As I told you, 2 implants were just removed, one on the right and one on the left. And we tried to give back the transitional prosthesis that she had. And now you can see, after we exposed the anterior implant in the location of the right central incisor, you can see the remaining implant, broken tip of the implant on the right side, and between the 3 implants on the left, there is a broken screw inside that we couldn't use this implant. We used only 2 of the previous implant, as well as the wisdom tooth on the right. So these 4 abutments, actually 3 implants and 1 tooth, used to hold this temporary prosthesis. If you look at the intraoral view, one can appreciate the amount of deficiency due to the loss of teeth and the loss of tissues. And this is the prosthesis that she had. So this is very poor prosthesis for a very young lady. And look at the intraoral view prior to the first stage. So this is at age 39 without the prosthesis. And you can see here the class 3, the severe acquired class 3. So first of all, we have to plan the location of the implants. So we plan, digitally planned 2 bridges, one in the right location of the future class 1 to support the lips and teeth, at the lips and cheeks. And the other one is the same bridge located in class 3. So you can see here the difference between the 2 planned bridges. The green is in class 1 and the yellow in class 3. And then we plan the implant. You can see them in green and purple, and the old implants you can see in red. Few transitional implants were also located. And with this template, with this fully guidance, we plan to place implants both on the right side and on the left side, new implants together with the augmentation procedure. So this was done under general anesthesia. And here you see the subnasal elevation procedure, the phase A. The right sinus elevation, it's a correction of the sinus elevation she had. On the left side, she didn't need. And the location of the implant simultaneously with the augmentation. One implant, old implant, were removed and new implants were placed. So I used xenograft material saturated in bone marrow, harvested monoblock from the symphysis to correct as much as I can the horizontal dimension. You can see here the PPP, the platelets poor plasma, covering the entire augmented area. I also fill with the same material the donor side and cover it with resorbable membrane and PPP. This is from the operation. A picture taken after vertical and horizontal augmentation by sinus subnasal elevation procedure and horizontal bone graft by autologous block onlay bone graft and simultaneous implant placement. This is the panoramic view after the operation. One can appreciate here the amount of bone, both at the subnasal elevation procedure on the right and left, sinus elevation procedure. And we have two transitional implants. We used 2 previous implants, the new implants and the tooth. I want you to pay attention here to the location of the previous implant and the angulation. The new trajectory of the new implant is different from the trajectory of the previous implants due to the fact that this, I think, was part of the previous failures because they tried to overcome the huge discrepancy between the upper and the lower jaw by replacing the implant obliquely. And in this case, it just didn't work. So these implants are in different trajectory because we plan to do an advancement, a leaf foot 1, and to place the implant in a straight position. So those are the implants we will use to support till the operation is done, the transitional and the new transitional prosthesis. And here you can see her with the new transitional prosthesis. Now, the question is, isn't it enough? Isn't she suffered enough? Why don't we just leave her with this and she will be happy? Why do we have to plan another phase with leaf foot 1 advancement? Let's just examine not only the occlusion, but also the aesthetics So if you look at the pre-op condition, while she was smiling, you remember she had here lack of support of the upper lip and the tip of the nose. And this is immediately after, and this is after the post-phase A, after augmentation procedure with the new transitional prosthesis. When she smiles, no difference at all. Although I did horizontal augmentation via block graft, there is not enough support at the nasolabial area. We still get this droopy nose and the lip is not support enough. Why does it happen? If we look at this scheme, we can see the depressor septi nasi muscle. It's a small, important, aesthetically important muscle. Its origin is in the maxilla, at the anterior maxilla. When the maxilla is retruded and the next point is in the tip of the nose, the nose is dropped down due to the fact that the origin of the muscle is lying too far behind. So if we move the maxilla forward, it will change the position of the tip of the nose and of course this nasolabial angle, which is too small. So this is just prior to operation to explain to you what is actually her position. This is the bridge in class 3. And this is the same bridge that we can put as class 1, which mimics the occlusion of the transitional bridge. So if we look at that picture, we have two bridges, which actually has the same occlusion, but they are connected differently to the implants. This is in class 3 and this is in class 1. And now if we do the operation, you can see the difference. When she wears this pink and white, this is in class 1. If we put the same occlusion in class 3, and then we operate her, we will do the forward and downward position of the maxilla, she will get the same occlusion without the pink area. So this is just prior to operation. And now we can scan the area both without the teeth, with the bridge in class 3 and with the bridge in class 1. And we send it all to plan the amount of bone that we need to change. Here you can see the digital, this we can see here, the digital occlusion, and then how we combined it with the CT digital of her face, the upper and the lower jaw, and then we plan the Lefort-1 osteotomy. One can see here, this is the location of the class 3, and this is what we desire to have. And if you look here in this number, it's about 10 millimeter that we need to do an advancement. So this advancement is huge, 1 centimeter advancement of the maxilla. And we prepare everything in advance. So we can see here the models, the 3D models prior to operation, and we do it digitally, the operation. We prepare even the holes for the screws, and of course the plates to fixate the jaw after the separation. And now we are ready to go for the operation. So I put the braces on just for the intermaxillary fixation during the operation. I will leave her with open mouth. We will not close her mouth. And this is just in the morning of the operation, the cephalometric view, the severe class 3, 1 centimeter needs to be advanced. I go to the operating room. This is my new operating room and my team. Of course, we have a team. and general anesthesia, of course, is done. Again, I harvest bone marrow. I extract the transitional implant. I add more implant as we planned, and now we start with the Leaf-4-1. I can take the screws from the previous operation, and now I adjust the template for the osteotomy, so everything is accurate on the millimeters. So we do the Leaf-4-1. I work with piezosurgery device, and this is already after the down fracture of the maxilla and the fixation with a prepared template. I use allograft saturated in bone marrow to overcome the huge discrepancy of 1 centimeter, and xenograft material, and then the buccal fat pad and PPP, platelets per plasma. I suture everything, add as much as I can bone, and now examine the occlusion in class 1, and that's it. It's over. Just a few minutes, I finish. And this is just at the operation and after the osteotomy, the Leaf-4-1 osteotomy. And you can see it's exactly the way we planned it digitally. This is a pre-op profile view. And this is a post-op profile view. I want you to pay attention to 3 points. The tip of the nose, I didn't do anything to the nose, but we make better due to the depressor muscle that were released from his posterior position. The nasolabial angle was improved, and the position of the upper lip. And if you look at the cephalometric view at time of admission and the cephalometric view just prior to surgery and the cephalometric view at the end of the operation, just to show you, we don't do on cephalometric view, as I showed you, we do everything on 3D in digital, but the point A needs to be anterior to the point B. And even after implantation and augmentation, point A was not forward enough. That's why we needed the Leaf-4-1 advancement. And only then we got the right proportion. And if we look here, we got the improvement both in the lip, nasolabial, and tip of the nose. If you look at the panoramic view, we have straight abutments. And every implant is covered with bone, and we don't need angulated implant or angulated abutments. This here is her transitional prosthesis in class 1, her facial scanning after the operation. This is pre-op and post-op. Look at the huge difference in facial profile. Pre-op in class 3 with the class 3 bridge, and post-op. Huge different, huge different. Pre-op, post-op, and she's a happy person. Thank you very much.